Okay, yeah, thank you very much for the introduction. And so the topic of my talk, this is my disclosure slide, is so if there's a murmur, if there's a noise related to the VSD, should we close it? You know, there's a Shakespeare theme on that topic. It's a different topic in regard, not regarding congenital heart disease, but it's about if there's any noise, should we care about that? And as we heard already from the previous speaker, there's things to care about if we have a VSD in patients. Especially, we have to look for a volume load, and if it's a smaller VSD, or we have to look for pressure load, or if it's increase of pressure in the patient. So that's what we have to monitor, and that's what we look for in regard to decision we make. So nevertheless, the question would be if this hole is causing a significant shunt, or if it's causing a significant volume load according to this shunt, and if we have and can measure this in our patients. Nevertheless, it's still also important if we know about the location of the defect in regard where it is, the size may influence also our strategy or the decision made. And again, for any strategy, including interventional strategies, is really important if we have enough area around this for our interventional strategy or even for the surgical strategy. And good. So what we really have to care of is the circumferential structure mostly are valves. So if we harm the valves with our interventional or surgical strategy, we also should be aware of that, and we also should think of that. I come to this later. And age and weight, we heard about, that may influence our strategy and the timing also. And nevertheless, there's a contraindication most likely in patients where we have proceeded or pronounced disease. So nevertheless, the question again is, what is a relevant shunt in the patient for the decision to close or not to close the VSD in our patients? So we heard about there's a shunt calculation. It's a significant shunt is defined above 1.5 to around 2.1 as a QP. So the pulmonary vascular pressure might be also increased, but the flow is increased in the pulmonary vascular system. So then we look for if this affects also our left ventricle in regard to left atrium or left ventricle dilatation according to this extra volume which goes through the lungs and comes back. Nevertheless, we have also patients where we have maybe a QP which is around to 1.5 or just above, and we have pressure load. So those patients may be also treated earlier as the other patients where we just have volume load. And maybe we have signs of the disease or of the volume load. So if the left ventricle is dysfunctioning with this volume load, or if the mitral valve is regurgitant. So I think we have to look also on that specifically in regard to the decision making. And we have some kind of risk of endocarditis in those patients if there is still a hole and the hole is kept there. So we had this question earlier, what should we do about the quantification of volume load? So if we just look for the left ventricle, if we look for a left atrium, if we can calculate by echo the QP to QS or by MRI, by any other things, or even do we have to do a catheterization for that purposes? I can think of many patients where we have a left ventricular volume load and we have an increased anti-diastolic pressure in our patients. So I think if we see volume loaded left ventricle, we should little care on that and maybe take specifically more a point to that this is also an addressable thing and treated, and the patient needs treatment. In regard to shunting, so I think there are four morphologies or four types of shunting. The first is the restrictive VSD, which is a small hole making some kind of shunting, and we can calculate it's around maybe 1.3, 1.2, and the pressure on the pulmonary vascular is not increased. So this is a restrictive, a small VSD. What should we do with this? So those patients are mostly asymptomatic. The echo shows a high velocity jet. The left ventricle volume may be not overloaded, so left ventricle diameter is normal, left atrial diameter is normal, so pulmonary hypertension is excluded by echo, and the defect size most likely is below 3 millimeters. So if we can calculate shunt and if we can exclude pulmonary hypertension, those patients have maybe no indication for treatment. And we heard about the murmurs. I think the murmur might be between holosystolic and non-holosystolic. So it's really, again, tells you most likely the velocity of the jet over the VSD. And again, I think those patients may have no indication for treatment in the area where we are. The second part may be a moderately restricted VSD. We have a lot of increase of shunting. We have an increased shunting which you can calculate around maybe 1.5, 1.6. So maybe just at the border where we wanted to treat or we think about. And the pulmonary pressures may also be higher or lower or even normal. So this is a moderately restricted VSD. And those patients may be initially asymptomatic and they can turn to symptomatic patients. So they may have some kind of dyspnea or tachypnea, or the patients may even have some signs on the X-ray. The velocity jet is still moderately increased, or the velocity is increased, and the volume load may be also significantly measured by, as again said, left ventricle volume, left atrial volume, or even mitral regurg. And the increased pressure can be maybe calculated or measured by echo or any other thing. So those defects mostly are a little bigger, and maybe those patients can turn us with a congestion. So they may have also failure to thrive, but nevertheless, those patients may get small diuretics in the follow-up, and those patients are followed over time. And those patients may show us that we have to do an elective treatment in these patients, which is in accordance to the shunt and the volume load or even pressure load. And the third group is the shunting, which is non-restrictive VSD. We heard about that. I think the timing is much easier in this patient because they show up earlier, they have more symptoms, and those patients are mostly early symptomatic. The velocity jet is not that high, the volume load is increased, even the pressure load is increased. We can calculate by echo or even anything. So defect size mostly is bigger and congestion may occur earlier. So these patients may have indication for early treatment. So those defects has to be closed. For classification of what we can close by either any kind of intervention or surgery, I think location is also important because there are some defects which we cannot close by intervention. Most likely these are the double committed VSDs, as we heard already. Even if the Chinese are doing some stuff there, I think aortic regurgitation is a major concern in those patient group, and I think I'm not convinced that this is a treatment where the incidence of aortic regurgitation is around 20% or even higher. So any other of those defects may be addressed by either intervention or either surgical things. So what is the outcome of these treatments? If we look for that, there are only a small couple of data around. So if we look for a good review paper on the comparison of surgical and interventional procedures or even treatment in these patients, this was a group of nearly percutaneous 1,300 and surgical 1,800 in a couple of 7 studies. So the mean age of patients in the surgical group is lower, which is related to the symptomatic patients and the treatment indication. The residual shunt in the percutaneous group was lower, so there's some residual shunt in the surgical group most likely, maybe in regard to the age again. And the need of blood transfusion and the hospital stay is a little higher in the patient group of surgical treatment. So in comparison to that, I think there is a clear efficacy on this patient group, but nevertheless, there is a difference in regard to the kind of things. Catheterization, it's not routinely done. I think there's only a couple of things where we need this. Maybe we don't have a clear picture on echo, so we cannot estimate the pressures most likely. This is an indication for a catheterization, mostly diagnostic, if we want to rule out pulmonary hypertension especially. And anyway, if we go for intervention closure, if the patient is suitable, or if we may need a shunt calculation, I think we have most likely more invasive things to do, or we have better methods now for that. And the coronary patients maybe have to be, or the coronary disease has to be excluded in these patients. So what again, if we compare now the percutaneous, we did a small research, and that there are also small numbers of studies around, even if this is a most common disease, 46 studies we found in regard to the interventional closure of the VSD, so the percutaneous closure, but only a couple of studies has a nicely pooled evidence for that. But nevertheless, for intervention closure, the success rate is really high, 96 and above. Mortality rate is really low, and we have some small case studies where we have a increased mortality, but the majority has a really low, nearly zero mortality. And the residual shunting was initially 25%, but it goes low, down to a low degree of 3% around on all these studies. So this is nice study data, but there's a side effect on percutaneous closure also, risk of arrhythmia, especially the AV block. It's around 10% initially and decreased around to 3%. The degree of AV block is low, but nevertheless it's there. And some of the patients need a pacemaker, even after percutaneous implantation. So that's some kind of concern in that treatment group, and especially most likely it may be where we push the borders or where we may implant bigger devices in smaller children especially. There are a couple of valvular defects, as I already pointed out, mostly the aortic valve, some of the tricuspid valve is also impacted by that. So the spectrum of device, we will hear later from Ingo, is there, and this is increased over time. So we have more devices for treatment, and we have different approaches now. We can make it easier by retrograde, or we can even do the antegrade approach. I think that may influence our strategy. Spontaneous closure is also to be seen. So in the small defects, there is a higher degree of closure over time. So 84% of defects which are below 3 millimeters are closed over time. But if the defect is more than 3 millimeters, the closure rate is much lower. But nevertheless, also the presentation, if the patient is asymptomatic and is a small VSD, 80% of the VSDs presented at the age of 1 month are closed over time, and it goes down to even the later presentation, the lower is the closure rate. And there are a couple of VSDs which are not closing especially. So what happens if we're not treating these patients? Endocarditis is a concern. Aortic valve prolapse is a concern. Aortic valve regurgitation can even happen if we don't treat the patients. Aneurysm or tricuspid dysfunction can happen. And we have maybe a reaction of the muscular in the right or left ventricle in regard to the VSD flow. And especially we have the risk of arrhythmia even if the patient is not treated overall. It's around 5 to 7%. And it's not, I think, not really a thing which we can lay down. And it is related to age and PA pressure. So if this goes up, PA pressure goes up and age goes up, the arrhythmia risk is much increased over time. Endocarditis. I think it's difficult to see, but the incidence has been shown in papers around 0.5 to 2%, and it's higher in the non-operated group, which is nearly double the time of than in the operated group. So this is a risk, especially most likely depending on the country where the patient is living. And I haven't seen so many patients with a native endocarditis of the VSD, but it is described overall, and I think it's happened more likely in the third world countries or in other countries where the dental hygiene and any other things are not well. So nevertheless, you have to close 100 VSDs to treat or prevent 2 cases of endocarditis, which was a poster in the APPCS meeting just recently. And I think, which is nice to see, so you have to do a lot for prevention of endocarditis. And again, the endocarditis risk in some studies is comparable in the treated and non-treated group. So this is really important, and this influences maybe the decision. We heard about aortic valve regurgitation, which is mostly if there is a pressure flow in the area where it is smaller, so the flow is increased with the velocity, and that may influence especially the valve tissues around. So that's happening over time. If the VSD is there, there's a prolapse risk of the aortic valve, most likely the right coronary artery, the right cuspid especially. This is the case where the VSD is causing aortic regurgitation, aortic valve dysfunction, especially if the VSD has a velocity which is increased. And if aneurysm in the VSD area is there, also the closure rate is lower. So this may influence also the treatment, and especially in this group, the freedom from treatment, either endocarditis or even advanced, that they call it advanced surgery, or endocarditis is even higher in the patient group where the aneurysm is there. So again, I want to stress out a little. If we have patients and we want to compare, we have a murmur, we have a disease, where we have a shunting, and we have a same indication or the same incidence of endocarditis in the PDA group as in comparison to the VSD group. Should we treat all the patients with the VSD, especially if it's a small VSD? And can we compare the treatment for VSD in comparison to the PDA treatment? So if treatment is safe, as I tried to show, every VSD should be closed as performed for the PDA in regard to all the side effects we see. Can we or should we? A couple of answers for that I think is difficult to find, but a couple of answers are around. There's a nice, again, meta-analysis on that. Our analysis, or they stated that their analysis a significant heterogeneity in the evaluation of management of the innocent, which is a small VSD, left to right shunts. So again, the strategy is not clear defined. And Krishna Kumar, I think, he wrote a recent really nice paper on that. So if a procedure is performed without a clear indication, no risk, however, even if it's 0%, should be small enough to accept for this. And I think that's why he said a procedure for treatment can also cause different side effects, especially the aortic valve regurgitation. So that's why he pointed out we have to be keen on that we have an indication for treatment and not just a murmur or a noise, which we try to treat, which is not causing any harm over time. And in the third world countries, we discussed it in Bali just recently. It's a must pressure in the patient group. Then if there is a VSD, they have to control them for every nearly half a year or even months, and which is really not really accepted in this community because of the resources and everything. So if the patient is treated, there's a discharge and the problem is solved. That's why in the Asia world, they treat even the small VSD more frequently than we do. So in summarize, so even if there is a noise, I think we should stick on that we close by indication and try to point it out what's the indications for the VSD closure in those patients. Thank you very much for your attention.